the blessing of God and our teachers, as they say, because I was discussing with one of my teacher, and he said, and on that innovation I will start, and asked to sir, Dr. Anil Chaturvedi sir, but as they say, when in initial part, जब गुरुकुल खत्म होता था तो 4 चीज़ें बोली जाती थी, the gratitude part, and the gratitude starts from the part, first is to the mother, second teacher, and the fourth they say is to the God. So this is the thing that one of the director of my school has said when I went to him, and the second thing he said was, the gratitude is the first thing in life that you have to keep, and it is in this priority only. The first is for the mother, second for the father, third for the teacher, and fourth is for the God. The second thing is be giver to the society, and we are some of the blessed ones as doctors that we are giver to the society. The third thing they used to say is to serve the part you have come for to the earth, whatever you can serve. And the fourth thing is, and one of the most important is, that you should learn every day. So the concept will be of this conference, and it has always been, this is the 5th time we are associating, and most of the person, I can see one of my senior, my parent figure, Dr. Anil Chaturvedi, he will start with the conference, and he has started with the conference from the initial first one. Dr. Vimal Nakra sir is here, and he was on the stage in that also. So most of the person here are, and I am blessed that we are together again. And some of the young generation of the Dr. Gandhi, Dr. Narayan sir, I said to him, sir, please come on time, we will be motivated. Dr. Gijesh sir, and they said that we will be on time, don't worry. And so to see all these faces in the start, I am motivated, and I am praying to the God, it will be a good session. So to start with the stalwart of medical field, Dr. Anil Chaturvedi sir, he needs no introduction in East Delhi, in Delhi and in India, one of the BC Roy awardee, API Lifetime Achievement Award was given to sir, National BC Roy Award, which is one of the famous award we all know and we all strive for in medicine in 2016, and all the Samanya Ministry of Social Justice Award, National Award for Science Communication, IMA, AKN, Sinha National Award. And one thing I can say, if you have to start with the oration, and they say that the success comes with the oration and communication, then if you have to see for the one doctor and one person in your life, then you have to start with the Dr. Anil Chaturvedi sir. So a single word in Hindi we used to say Ojas Vani. So Ojas Vani will be started from feet of the sir, and that everybody knows. So, and sir will also guide us. Sir is now Chairman Preventive Health and Lifestyle Disease, Goel Hospital and Urology Center, Delhi. So over to sir for the welcome address, and we are privileged, and for the session. Thanks a lot.
सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामया, सर्वे भद्राणि पश्यन्तु, मा कश्चित् दुःखभाग् भवेत्. May all be healthy, may all be happy, may nobody suffer in any way, may people have well-being of all in mind. It is with this idea that Dr. Pawan Sharma started this CardioCon 5 years back, and every year the conference achieves its new heights. It is sheer his determination, and single-handedly he has organized these conferences. True to his name and worth his reputation, Pawan means Vayu, Hava, and it's faster than anything else. In last 5 years, this conference has made its name, and it is sheer because of his determination, dedication, devotion, courage of his conviction and commitment that we all assemble here on the 5th occasion of this conference. This conference is unique because after 2 years, we started hybrid plus physical, and the subject he has chosen today and the speakers are very apt and appropriate. They are all excellent teachers. Dr. Balbir Singh, Dr. Rajiv Agrawal, Dr. Vivek Chaturvedi, Vijay Trehan, and Dr. V.K. Bahal. The subjects are very apt and appropriate, and I am sure this conference will enlighten us and take us to new heights as far as the practice of cardiology is today. With this introduction and welcome, and I welcome you all to this conference, fifth conference, and I am sure this will serve the purpose to enlighten us, educate us on the various basic aspects of practice of cardiology for general physician and family physician. With this, I conclude my welcome address, and I request Dr. Sharma to start the first session.
So, respected sir, the first session will be taken by Dr. Anil Chaturvedi sir himself, and I will ask some senior members, Dr. Arvind Narayan sir, to chair the session. Dr. Vimal Nakra sir. Dr. Arora sir. So, sir will be deliberating a speech on. Sir will start with. Right.
Okay. Illustrious chairpersons, Dr. Nakara, Dr. Arvind Narayan, and distinguished delegates. The first topic, I thought that every conference must start with something, as Dr. Pawan Sharma said, something to do with our ethics and morality, and my subject of today's talk is ethics in cardiology practice, and is of great relevance today. Long time back, nearly 100 years back, the father of modern medicine, who enunciated the ethics in practice of cardiology, or general practice, could realize the complexity and the perplexities of our profession when he said, life is short, art is long, occasions fleeting, experience fallacious, and judgment difficult. What it said 2005 years back, it still holds true today, and that is why we are forced to discuss and compelled to discuss ethics in the medical practice today. And as per the Delhi Medical Guidelines and Medical Council guidelines, all the conferences today must have one lecture on ethics or legal. So, realizing this, in Leicester in 1992 wrote in Washington Post, the culture and roles of medicine have suffered relentless erosion. Our profession now stands in urgent need of a transfusion of idealism, hence the topic and the conference. Chirac said, the physician should regard all his patients as they were his own children and vigilantly guard them from all harm, considering this to be his highest religion. Today, now the ethics deal with distinction between right and wrong, with moral consequences of our action. The purpose of illuminating our actions with ethical consideration is to clarify the issues so that logical and ethical acceptable decisions can be made in ambiguous situations. Now, cardiology is a branch of medicine characterized by state-of-art biomedical technology. Evidence-based medicine is incorporated in the practice of cardiology, and ethical dilemmas known to the specialty arise from the decisions to be made between what can be done and what should be done for varieties of cardiovascular pathologies. Now, when a medical practitioner or especially a cardiologist have ethical dilemmas, situations, how do we balance individual with social needs? How do we ensure that quality of care is reconciled with equity and not used as a pretext to serve the interest of the law? Few, if the development of technology is driven by market forces, what happens to the principle of health for all? How do we ensure that research and health development take into account the needs of the poor and provide them with effective health care and services? These are the basic questions which all linger in our minds. So what are professional ethics? Some of the important components of the professional ethics that professional organizations necessarily include in their code of conduct are integrity, honesty, transparency, respectfulness, confidentiality and objectivity. Everybody, when he becomes a doctor, you all have a code of medical context enunciated by the Medical Council of India. I'm not going to repeat them, but I'm just going to give you a practical aspect of all those. Ethical behavior. Our code of conduct is also derived from ethical behavior, which includes, again, integrity, fairness, honesty, and dignity. They are fundamental principles of ethics. That is, the fundamental principles of values are featured in most healthcare professional code of ethics and conduct, and they are very important. Autonomy. It means role of the patient to retain control of his body, right of the patient. Every individual has a right what should be done with it, and that is his autonomy. That is the fundamental principle of law and ethics in medical practice. Beneficence. Do promote what is best for the patient. Non-maleficence. Do no harm to the patient. These are the basic. Justice. Equity, not equality. There should be an element of fairness in decisions. Resources are limited. We cannot cure everybody, so priorities must be set and adhere to our professional duty. Those who need can I have the glass of water? Should be given the priority right. Emergency situations, urgent situations, those people who require immediate medical care, irrespective of their financial, should be given priority. Confidentiality and privacy. This is a very important aspect. Every patient comes to a doctor with some trust, faith, and confidence, and that must be not breached at any cost. Confidence and faith, and today we believe that the patient and doctor are partners themselves. There are certain myths about medical advances. Experimental standard care are well defined. Doctors adopt medical advances only on the basis of good science. Newer is always better. More medical tests are always better. Information can only be good. Doctor adopt new treatment only with those treatment offer good value for money. We can cure most medical conditions. The proliferation of technology and techno drugs have changed expectation as well as techniques. Perfect health is too often viewed as a patient's right and the physician's responsibility. People expect absolute care without any risk, complication. There is a belief that the more technology is applied, the better the outcome. And today, people want 100% guaranteed results, which is not possible. But this is what the myth, this is what the expectation of the public is. Probably we are also responsible for certain part of it. New technologies have altered the relationship between doctor and patient. Specialized physicians know more and more about less and less. Doctors treat diseases rather than people. Medical schools teach the science but ignore the art of medicine, and medical technology is outplaced moral understanding, and hospitals have become old impersonal mazes. That is Thomas Cole said in Lancet 2009. Healing is replaced with treating, caring is supplemented by managing, art of listening is too taken over by technical procedures. Doctors no longer minister to distinctive person but concern themselves with fragmented, malfunctioning biological parts, and the distressed human being is frequently absent from the transaction. Society places a major premium on technology than the listening or counseling. Time spent in an operating room or performing an invasive procedure is rewarded tenfold than conversation with patients or family. And current medical practice focuses on the acute emergency medicine and is largely indifferent to preventing health and promoting health. Since preventive medicine, though recognized as the most cost-effective approach to illness, is time-intensive, is completely neglected, and diligent prevention invariably plays second fiddle to heroic cures. Sir William Osler said, "The practice of medicine is an art, not a trade, a calling, not a business, a calling which your heart will be exercise equally with your head. Without reflections, we cannot see ourselves. Sometimes it takes contrast to appreciate the steady and the familiar." इंसा वही इंसा है जिसने देखा है हकीकत को हकीकत की नज़र से, और ज़माने में उसने बड़ी बात कर ली, खुद अपने से जिसने मुलाकात कर ली. We must realize the reality. हमें अपने गिरबान में भी झांक के देखना होगा, and this is the time we should do that. Today, in the practice of cardiology, is not Anil Chaturvedi saying, I will prove by subsequent literary evidence, document evidence, the stunt of statin and stent. To be or not to be, that is the question William Shakespeare wrote, quote, in 1567. And today, every physician, to statin, not to statin, should statin for everyone, put statins in the drinking water. Today, I have no hesitation to say the practice of medicine is governed by the market forces. And as long the market forces will continue to govern our practice, this situation, we will never come out of it. Cholesterol overhaul, new statin guidelines from your big pharma company and friends. The most distinctive feature of the Indian statin market is the number of products available to consumers and the number of manufacturers that produce the product. Only a minority of patients who would receive the statin therapy in other countries appear to be receiving the therapy in India. In India, there are approximately 80,000 medical representatives who give physicians and pharmacists financial support to attend conferences, who sponsor their recreational trips, and who provide them with smaller gifts, all on behalf of the pharmaceutical manufacturers. Indian pharmacists, in turn, brand names drugs to consumers who may have difficulty evaluating the quality of recommendations being made to them. There are 4 articles by Goyal and Parikh in Journal of Business and Management, a review article in prescription behavior of the doctors influenced by the medical representative. Bansal and Dasar wrote in Indian Academy of Forensic Medicine, unethical relationship between doctors and drug companies. Patel J. wrote in Bombay Hospital Journal, the gifts and trinkets to doctors, current practice in Indian and global trends in pharmaceutical industry, and therefore, National Medical Journal, they wrote the Medical Council of India guidelines on industry-physician relationship, making the conspiracy of silence. Don't let big pharma ruin your health. Wake up to the cholesterol. Statins can kill. Cholesterol does not. What is doctor does not know that it can cause muscle cramps, joint pains, impotence, extreme lethargy, tinnitus, weakness, weight gains, cloudy urine, hopelessness, memory loss, rage behind reason, personality change, getting old. Unfortunately, most of us work in a hospital where they're CGHS patient. They keep on taking the medicine for 6 months or so. They insist on doctors to repeat the same medicine, but never get the test done. I have seen patients, and Dr. Nakra must have also seen, lot of people have come with 20,000 CPK, rhabdomyocytes, have to be admitted because they never went to the doctor. For 2 years, they have been consuming statin left and right. Even one patient, if you see in your life, I have seen 4 or 5. That's why I'm too scared to prescribe statin to each and everybody. 6 side effects of statin medication: weakness of limbs, weakness of hands, muscle pain, liver problems, stiffness, and fatigue. Lifelong early reduction in LDL. We all know cholesterol is likely to result in the largest absolute risk reductions. Thus, public health programs emphasizing diet and lifestyle changes in youth and young adulthood must also be aggressively implemented. See, we live in a country, the cholesterol epidemic, what I'm saying, the statin epidemic, because they have been all populated, promoted by the Western countries. Their ethnicity is different. Their environmental factors are different. Their race, religion is different. We are in a country where lifestyle changes, we believe in yoga, and that is the polypill. There is a thrill to prescribe the pill. The pill not only increases the bill, but it can also kill, you have seen. So, yoga is a lifestyle polypill. Professor Dr. S.C. Manchanda is a great proponent of yoga, and he said, yoga is a lifestyle polypill. He has written a lot of articles, and he has proved with scientific literature, documentary evidence that yoga is a very helpful. So, दुनिया में भांति भांति के लोग करें अनेक प्रकार के भोग, उन्हें लगे नाना प्रकार के रोग, और योग और साधना भगाए सारे रोग. So that's why, and yoga, it is India who proposed in 2017 International Yoga Day on 21st June, and now the World Health Organization has also recognized the efficiency and effectiveness of yoga, and Yoga Day on 21st June is celebrated in 170 WHO countries. Professor Kombolow's Cardiac Procedures, Outcome and Accountability in NAGM wrote, in a free-for-service system, cardiac procedures generate billions of doctoral revenue such year. A high volume of procedures brought prestige and financial rewards for hospitals, physicians, and the vendors of the medical equipments. There is always a profit motive in those ventures that make the employee to perform or perish. Most of our skilled laborers in this new hospital industry, young interventionists are therefore egged on to do more and more, and Mark Twain said, for a man with the hammer in his hand, wanting to use it, everything there looks like a nail needling hammer. Only Bernard Lawn, Second Opinion, Trial of Coronary Angiography in JAMA wrote, only 3% of the 200 patients referred to Center for CABD by local cardiologists scientifically needed the procedure. The rest were followed for 15 long years without any adverse effect. This is Bernard Lawn, the famous, who wrote Lost Art of Clinical Medicine. Angiogram is indicated only as a prerequisite for plumbing and should only be done after the decision to revascularize the made on the patient's clinical condition. Done earlier, this might frighten the patient and relatives into agreeing for the procedure unnecessarily. Reducing cardiac angiography setups in the UK would avoid their overuse. Professor Hampton of the Duquesne University found in one of his studies that his area more than 47% of the angiograms were inappropriately done. Audit of a coronary and arteriography and bypass, it was in Lancet editorial. Lancet, do epidermis cause epidemic? Diagnostics tests are another area where overdue testing is a big way. While good clinical science could get most accurate diagnosis, in the majority, routine tests like a stress test and echocardiogram could have throw up false positive in a big way. The disease-based statistics applied to the vast healthy population should perforce bring about large number of false positive. Cardiac neurosis have gone up exponentially in recent years after these tests were introduced, more so because these tests are interpreted in many cases by centers with inadequate experience. There were 25 ECGs sent to 25 cardiologists, and not than 5% have the same opinion of the same ECG by the top cardiologists in a survey. Doctors often scare people in unnecessary stenting. The Times of India wrote, stenties in the USA have shown almost half the cases of stenting may have been unnecessary, and cardiologists in India also have admitted that inappropriate stenting is quite preventing here too. Too many stents can kill you, one study. The audit published in the National Medical Journal PLAS 1 found that 4.5% of the patients under the Rajiv Gandhi Arogya Yojana were studied died without a year of angioplasty. The intervention might be divine, but aim should be to make the patient feel better at the end of the day. Medicine revolves around anxiety, patient anxiety of disability, death, and the doctor anxiety of doing more and more. Doctors, including intervention, should try and allay these anxieties and not add to it. Long-lived medicines which aims to cure rarely, comfort mostly, console always, and let us try to do most of the good for the most of the people at most of the time. Medicine is not only science, it is all an art. It does not consist of compounding pills and postures. It reveals the very process of life which must be understood before they may be guided. The most frequent complaints against doctors, lack of time has made of well doctors. Sir William Osler said nearly 118 years back in... Okay, yes. They do not listen, they do not give information, they show lack of interest. Smile, open posture, forward lean, touch, eye contact and nod. Most errors in the clinical medicine are by making cursory examination. Without knowledge, empathy and highest ethical standards, no one can be a true good physician. What the patient wants, good communication, patients who are warm and sympathetic, doctors who easy to talk to. What important, not exacting knowledge, but your ability to keep it refreshing and dynamically, which Dr. Pawan Sharma is doing, organizing this conference. The efficiency and the effectiveness of medical interaction will be enhanced if the physician converses with concern and creates an expression of leave an everlasting impression. Medicine is a trying profession, but less because of the difficulties of disease than because of the difficulties of having worked with other human beings under circumstances notably only in partly one's control. Our aim is, our team is like a sport. The stakes are people's life and we have no choices. Doctors are exposed to coach themselves. Success in medicine, diligence, the necessity of giving sufficient attention to detail, and medicine is a fundamentally human profession, therefore troubled by human feeling like avarice, arrogance, insecurity, misunderstanding. It is a difficult art to talk medicine in language man. Without what all the doctors heal can injure, they have a far greater potential for healing. Patients have craved caring, which is largely with talk. Communication is the most powerful therapeutic force. Thank you, doctor. I feel like you really understand me. Patient says so. Medicine may be necessary. Flower lifts the heart, but your warm and friendly smile, your caring and leaning touch are the best restorative of all. The medical profession is not an occupation. It is a preoccupation. It is not a profession, but it is an obsession. It is not a means of livelihood, but a life full of commitment. As somebody has said, for a person like Dr. Pawan Sharma and Dr. Nakara and others who are saying, हम तो अभिशापों से भी वरदान जुटा लेते हैं, गम में भी खुशी का सामान जुटा लेते हैं, वे हैं मनुष्य जो रो रो के जीते हैं, हम तो आंसू से भी मुस्कान जुटा लेते हैं. Every physician should try to do that, and that is why survey, and that is what we should do it. Thank you very much.
So, beautiful presentation by Anil Chaturvedi sir, and I will request our chairpersons, if anybody from the audience want to ask something, then they can ask. Although Dr. Arvind Narayan sir has summarized it, that, and sir has also said that two things I have learned. The first thing is from all our teachers also, the first 5 minutes belongs to the teacher. The first 5 minutes belong to the patient as a physician. पहले 5 मिनट तो उसकी सुनना है, फिर चाहे आप कुछ भी करो, ठीक है. And Vivek Chaturvedi sir is with us, Professor Vivek Chaturvedi sir, and he has said, जब हम discuss कर रहे थे कि what are the practical misjudgments, then sir was rightly in saying that the best thing is, अगर हम history अच्छे से सुन ले 5 मिनट तो most of the thing will be vanished by that. तो पहले 5 मिनट तो patient के हैं, और उसके बाद जैसे सर ने कहा कि होलिस्टिक अप्रोच, वी ऑल थिंक सो, होलिस्टिक अप्रोच इज द बेस्ट वन, एंड देयर इज फॉर एवरी पेशेंट वी हैव टू स्क्रूटनाइज इट एंड लेबल इट एंड देन डिसाइड फॉर द मेडिकेशंस. तो सबके लिए अलग शायद दवाई है, या उसी तरह जैसे जैसे हम मैच्योर होते जाते हैं वैसे वैसे शायद हम स्क्रूटनी करते चले जाते हैं. सो आई एम थैंकफुल टू सर एंड ऑल्सो टू आवर चेयर Dr. Vimal Nakara sir, to Dr. Narayan sir, Dr. Dhaka sir and Dr. Arora sir. Now I will ask to felicitation of these. Please, Namit, एक बार उधर से ट्रॉफी, कोई बात नहीं, आप ही ले आओ, चलो आ जाएंगे अभी. आइए सर प्लीज. ये तो सर.
Hello, Dr. Chaturvedi, it's very nice presentation, and I think I agree with Dr. Pawan also that initial you must listen to the patient, then comes the decision of the medicines and the procedure what you want to do, and before doing the procedure and medicines it is the counseling of the patient. That is very important in ethics, because if you don't counsel and you believe in your superficiality practice and you believe in your expertise, patient may not feel contented and he may go dissatisfied. And there are the court cases which are because of all this miscommunication only. I think Dr. Chaturvedi has made his point. Thank you very much.
Dr. Chaturvedi is an encyclopedia of life. He has shared all his experiences and knowledge to all of us. Thank you, sir.
Yeah. Yes, thank you very much for Dr. Chaturvedi. And only one line I would like to say. We have to maintain this ethics, medical ethics at a high level to maintain the nobleness of this medical profession. Thank you very much.
To move on, our next session is from the Professor Dr. Balbir Singh sir. Sir needs no introduction. Sir is chairman of Max Healthcare, and sir was a senior professor in AIMS cardiology. Then journey starts from there. Then Batra, and after that in Fortis Medanta, and now sir is chairman Max Healthcare based in Saket. And one word I can say, if you don't know anything about any patient of arrhythmia or even intervention cardiology, then you can refer for the hope. Sir is the one of the person who is hope for the every end. Where our thinking ends, sir's thinking starts with that. And sir will enlighten us on the topic stable heart failure, improving outcome in heart failure with reduced ejection fraction with the right therapy choice. And I will request for the chairing the session, Dr. Professor Vivek Chaturvedi sir, please. Dr. Anil Chaturvedi sir, please. Sorry, Dr. Vivek Chaturvedi sir is from the AIMS, MBBS, MD, DM, and Dr. Anil Chaturvedi, as we were just discussing, we all know. And Dr. Gijesh Rohtagi sir is very senior physician from East Delhi. So, I will hand over the things to Dr. Balbir sir to start with. The session will be a virtual. There may be some glitches from our side, so we are pardoning from. So please, my apology for both the sides.
Actually, I am from 83 batch. I did my MBS MD from 82. Graduation was 3. He's my cousin. Pawan Khanna.
There is some sound problem.
70 despite all these medicines. So we have to choose these drugs. So the current scenario of guideline-directed medical management is the guidelines recommend that to get these optimal outcomes, you should have all the 4 drugs which I mentioned, the 4 pillars of heart failure management by 1 month, and simultaneously using them, managing their drug side effects is the key a physician has. So the classical example is when you are adding multiple drugs, you have to come out as to have the least side effects. So ACE inhibitor, ARBs and beta blockers had played a long, good role in medical management for a long period of time. Diuretics were added to relieve symptoms, nothing otherwise, but the aldosterone antagonist helped to reduce mortality. Hypertension, ischemia and diabetes need to be treated, and symptom reduction is also the key. However, the drug cocktail, if you add all these 4 drugs, adds on some adverse effects, causes some poor adherence to therapy, and could lead to some medication errors. How to use the doses properly, how to combine them, is a challenge which many physicians are facing. Comorbid conditions are important in heart failure, like lung disease, atrial fibrillation, obstructive sleep apnea, renal impairment, diabetes, anemia, so heart failure with combination of all these things, leading to polypharmacy.
What is the right combination of these drugs? This can be seen from the ACC 2021 consensus, which states that start to then be immediately motivated. Initial stage, patient should be all these drugs to get the best outcome. First step is to initiate and switch to new therapy. Important. So to assess the tolerability of medication, assess the trajectory of the populations to have more clinical follow-up after initiation of this therapy. So if you look at the evidence, they have both younger age and at age more than 65. So comprehensive therapy extends event-free survival in this patient. So combination of SGLT2 inhibitor, MRA, beta blocker and ARNI can be used as a new therapeutic standard in heart failure. So the recommendation is that at 1 month, a patient should be on all these 4 drugs. You may have to titrate MRAs, you may have to titrate beta blocker, ARNI, SGLT2 inhibitors do not need any titration. They have fixed dose, 10 milligram of dapagliflozin. Both are equally effective. So in conclusion, I would say that initiate sacubitril valsartan as the first line therapy for our Indian patients to keep them out of the hospital. 75% of patients do not receive these optimal drugs. ACC 2021 consensus recommends initiation of guideline-related medical management as early as possible. Sacubitril valsartan is recommended as a first line in many patients. If we go on to see how many of our patients are actually on this combination of 4 drugs at 1 month, you would see that not too many. And we have to make sure that many more patients will get to these 4 drugs. Beta blocker, SGLT2 inhibitor, ARNI, and MRA. If we want to save many lives, this is the way to go. Each of these 4 drugs have shown to improve mortality, to improve rehospitalization in heart failure, and this improvement goes in the long run. So initiate with RD when the patient comes to you, add a beta blocker, so add these 2 drugs. You could add an SGLT2 inhibitor, you could add an MRA because if the protection gives you that chance. But do it fast, and at 1 month make sure patient is having all these 4 drugs. Thank you very much.
Thanks a lot, Balbir sir, and it is privilege to listen to Dr. Balbir sir. And as we know that this is the heart failure is one of the things with 50% mortality in 5 years. And sir has emphasized the points. 75% of these patients don't get the adequate optimal GDMD treatment. So this disease carries worse prognosis than any of the cancer, and this should be so the positive benefits should be passed on to all the patients. Now I will ask, is there any question from Dr. Vivek sir? He is also, Dr. Vivek Chaturvedi sir is one of my teacher, and usually his comments please.
Thank you so much, Doctor. As usual, always very, very informative when we lucid talk by Dr. Balbir. The question I would like to ask Dr. Balbir is if he can also clarify the revolutionary role these agents are now having in on the creatinine clearance, on the EGFR, because that has a strong interlink with the overall well-being in patients with heart failure and reduced ejection fraction. And there is a lot of data now that both RP and SGLT2 also have a very, very good effect on the kidney function.
I think there is some voice issue, so we have to link for it. Hello? Balbir sir, is voice clear?
Yeah.
Is question?
I can hear you.
Achha, you are not able to hear, sir? The question from Dr. Vivek, sir?
I could not get the question.
Okay, again, sir, could you come here and it will be
So, as I said that, as usual, a very lucid talk by Dr. Balbir.
Sir, are you able to hear now?
Are you able to hear me, sir?
Vivek, sir, if possible, could you come here? Sorry for pardoning. These are glitches that we doctors are not.
As usual, a very lucid talk by Dr. Balbir. I would also like him to say a few words on the salubrious effect these agents have on the creatinine clearance, because I think that is another challenge in patients with heart failure and reduced ejection fraction.
So both these drugs, ARNI and SGLT2 inhibitors, are beneficial to the renal function. If we look at the ARNI data in the Paragon trial and in the DAPA-HF trial, it was clear that the patients who were on DAPA or ARNI benefited in terms of the renal parameters. So there was less decline in renal creatinine clearance and improvement in the renal function. But a caution is when you start ARNI, there may be a slight bump in the serum creatinine level. It's quite expected, but over a period of time, it will stabilize. The creatinine clearance will improve, and both the drugs have been actually beneficial in the renal parameters. But what is the cutoff where you do not want to give ARNI or an SGLT? So EGFR less than 30 is when both these drugs do not have the favor as of now to be used.
Any other questions, sir?
Yes, illustrated it very well because we have all experienced this problem that when we give them diuretics and everything, after some time there is a resistance, and overall because of cardiorenal syndromes, there is progressive decline in both heart function and kidney function. These two agents have been shown now to have to kind of stall this relentless progression of decline in the glomerular filtration rate. And there is enough trial evidence for both now. The only word of caution is that in the first 4 weeks there might be a decline in the GFR, but then it comes back and stabilizes again. Naturally, you need to be very careful and have frequent monitoring. For both ARNI and DAPA, it is less than 30 creatinine clearance you should not start, and for empagliflozin it is 20. So the data was less than 20. So I think overall, at least 75% of heart failure patients can be easily offered these two.
So thanks a lot, Balbir sir, for the music talk, and Dr. Vivek sir and Balbir sir has enlightened us, most of the cardiologists also. For example, even I was afraid of some time because of this cardiorenal syndrome, but both of you has cleared it, and to the most of the audience here and online audience and physical audience, that you don't have to afraid for the most of the medications, as initially also that is why the 75% patients are not able to get these medications, because we are afraid of sometimes side effects. But you have to be observed to see for the creatinine clearance after 4 weeks and see for the initial creatinine clearance, and you should be judicious in your prescribing, but don't be afraid of, and the benefit should be passed on for the every medication which is available for such a life-threatening disease. Thanks a lot to everyone for this session, and it was a wonderful session. I am again privileged to have Dr. Balbir sir on the with us, because it is his Ashirwad always with us, and as a chairman Max, I am privileged to work under his leadership also. So thanks a lot, sir. Thanks again, and thanks to Dr.
Thank you very much.
So on the podium, I will request for memento. So please. To the Vivek Chaturvedi sir from Dr. Anil Chaturvedi sir. We are moving on to the next session, and this will be taken up by Dr. Rajiv Agarwal sir. Dr. Rajiv Agarwal sir is from Meerut, and he is director Jaswant Rai Hospital in Meerut. Sir is alumni of GB Pant Hospital, where most of us belong. And sir is dedicated working for last 30 years in Meerut, and sir has his philanthropic efforts also, and he is working for the pacemakers for poor persons, which is a life-threatening disease, and he has Limca or Guinness Book of World Record name with him because of this pacemaker implantation in poor patients. So to be fair to me, sir is associated with all the conferences for 4-5 years with us. He is a gentleman, a very good person, and he will enlighten us on the topic recent advances in SGLT2 in heart failure with reduced ejection fraction. So I will invite Dr. LKS Sinha, sir, senior physician, for the chair. Dr. NK Gupta, sir, please. Dr. Arjun Singh, sir, please. Now over to Dr. Rajiv Agarwal, sir. Sir, please. Should we start?
Dr. Pawan, are you able to see my slide?
Yes, sir. Very clear and very sound. And it is a great morning for me to see you lively.
Thank you. It is very cold in there. It must be cold in Delhi also. You just heard Dr. Balbir's holistic, hilltop view how we manage HFrEF, and he not only talked about very lovely slide I have created for you that what took us 2000 years, Egyptians knew that heart and kidney they go hand in hand, and they used to replace them in mummies so that they can be of purpose in afterlife. And that is the essence of SGLT2 universe. This is a slide which I have taken from Jack heart failure recommendations, a very recent slide, and just emphasizes whatever you see today may not.
Excuse me, sir. Sir, your slide is not in slideshow mode, sir. Excuse me, sir.
Yes.
Sir, please go to slideshow mode, sir. Your slides are not in full screen, sir. Yeah. Now click on share screen button. Then double click on first option, sir. Screen or entire screen.
Now I am visible.
It is coming, sir, but it is not in full screen, sir. Please go to slideshow mode.
Rajiv sir, you are visible. The recent advance in SGLT2 is heart failure. Now your slides are visible.
या एक बार F5 दबा दीजिए सर F5.
Yes, you are.
No, not in slideshow mode. Pavan sir, slideshow mode पे नहीं है ना, full screen.
Sir, full screen is not visible. He is saying slide show.
हाँ सर, yeah, sir, please stop share, sir. Firstly, yeah. Now click on share screen, then double click on first option, sir. जो first option है ना, entire screen और screen, उस पे click करके share कर दीजिए, sir. Yes, sir. Thank you so much, sir. It's done, sir.
Now we are good, sir. Slide is very well visible. Yes, sir. Now we are good.
So whatever, this is a very important message that whatever you see today may not be a reality in time to come. Some patient may deteriorate, some may so, and some may improve, and talking about new three terms that this is a worsening of ejection heart failure with worsening of ejection fraction, heart failure with recovered ejection fraction, heart failure with unchanged ejection fraction. There are new three terms introduced by Japanese Society for Heart Failure, and we should constantly at yearly basis should review our ejection fraction. We do not need to continue on the same understanding what we had at zero or the first day. So what we have learned so far, if you look at the trial design, I am very stickler to trial design because I keep repeating that until unless you see the trial design, you won't be able to understand the patient population in your clinics. And this is just that representation that all the trial design differed. Initially, we have tried to prove that with this patient with atherosclerosis relatively well operating function, and later on down the line, a patient where both type 2 diabetes and no diabetes with worsening renal function coming to the near clinical scenario where we have tremendous overlap between diabetes and renal failure and heart failure. So trial design is a very, very important thing to find out particular patient in your clinic and just start by combining two trials, DAPA-HF and AMPER reviews. These trials were not designed to talk about renal outcome. What they showed and the heart failure, the SGLT2 inhibitors are very good heart failure trials. Complementary, supplementary or opposing role of RE, we realize when we combine whether we use RE or don't use RE, doesn't make difference. These are contribute to benefit, but in AMPER reviews, when you combine RE, the effects were more than without RE. So probably it was a sicker patient, and when these two drugs were used together, they were more beneficial. So let me summarize, there is no competition between RE and SGLT2 inhibitor. They should be combined, and the effects are not much additive except in AMPER reviews. If you look at the all-cause mortality reduced in these two trials in pooled analysis, if you look at CV death, it is reduced in pooled analysis. Renal outcomes are better in this trial than they are combined, although the pooled data was designed to talk about renal outcomes. This is another very wonderful study by Darren where it talks about type 2 diabetes mellitus, cardiovascular and kidney outcome, and again gives a lot of insight. If you look at the overall base in all the trials, if you look at the outcome in relation to ASCVD status, you find that the outcomes are, the primary base is more reduced or significantly reduced in patients who have ASCVD. So, giving you a concept that patient is higher risk, more outcome is there with SGLT2 inhibitors, and the primary outcome or primary risks are not significant. Another way to look at it, the overall CV death, if you look at the pooled data, it is significant. But if you look at the ASCVD status, it is significant. If there is no ASCVD, there is no mortality reduction. So once diabetes is without ASCVD, the primary base is not significant, CV death is not achieved. Another way to look at the heart failure is reduced in the pooled data. But if there is ASCVD, it is significant. But if there is no ASCVD, even then, heart failure is reduced. So heart failure is one characteristic of SGLT2 inhibitor, which is very beneficial even in patients who are low risk or not having ASCVD. Same way, the kidney outcomes. When you pool the whole data, it becomes significant. If you look at the ASCVD in the background, it's significant. If there is no ASCVD, then even it is significant, justifying good drug even without background ASCVD, and benefits are achieved both in heart failure hospitalization and preservation of renal function. So now we have started talking about a different primary MACE, what we call a major adverse renal and cardiac event. Probably FDA will mandate this, that it is necessary. And this is like all the patient population, if you judiciously use drugs on human front, a large number of our patients have cardiac syndrome in heart failure. This is a very good study which is recently published and talk about that SGLT2 inhibitors, there is less of kidney stone formation in comparison to GLP-1 receptor analog. The mechanism is not known. We know they are uricosuric, but what the workers has hypothesized, the urine flow is increased, urine output is not increased, so probably urate crystal, they don't form crystal. But this is a fact that in comparison to GLP-1 receptor analog, SGLT2 inhibitor, there is less of renal stone formation. I don't know whether Balbir is on board or not, because I wanted his comments. We know the overall mortality is being reduced in idiopathic dilated cardiomyopathy. Paradigm heart failure had been a landmark study, and we know now that in idiopathic dilated cardiomyopathy, the empirical primary prevention ICD is being challenged, and it is downgraded to class 2A, although Americans have class 1A indication. When you put dapagliflozin on top of Paradigm, what you see in LAPA-HF, and this is the way you can see there is an advantage at 18.21. So probably in idiopathic dilated cardiomyopathy, we have another anti-LP drug, which is a heart failure drug, and protected. Unlike empagliflozin, which increases statistically non-significant 14% in empiric outcome incidence of atrial fibrillation, the incidence of reduced in DAPA-HF. Not only the first, but the cumulative events are also reduced and p-value is highly significant. So I'll say C-DAPA protective, rhinoprotective, and anti-allergic drug in the background of atherosclerotic disease. It prevents CV mortality also. Now, how I summarize the whole thing on the whole high-risk type 2 diabetes, chronic kidney disease, heart failure. As the risk increases, the absolute risk reduction increases. And this is exactly in parallel with lipidology. You have low risk group, moderate risk group, high risk group, very high risk group, and extreme high risk. Similarly, if your patient is very high risk, SGLT2 inhibitor will give you very good absolute risk reduction, and that happens in risk of heart failure hospitalization as well as in risk of CV death and heart failure hospitalization. As the background risk increases, the outcome improves, and probably that is the strongest thing we should carry home and should empower you. Who are the people where NNT will be very low? If you have chronic heart failure, the NNT is just 25 to 31. If you look at the primary base, then it is 19 to 26. This is another way to look at it. The journey across the same way, another way to look at it. There are patients who are higher risk. In Soloist, we had patients who had recent worsening of heart failure. It's still sicker patient. The NNT is just 10 and relative risk reduction is 29%. So I want you to carry home message that SGLT2, like any other drug, behave the same way on the post-risk profile. Do not get confused with type 2 diabetes mellitus and heart failure. Look at the holistic approach. Look at the patient profile. Higher the risk of the patient profile, more is the absolute risk reduction. And we can conceptualize, like in ASCVD and atherosclerosis, we have different groups. Similarly, we have high risk in heart failure patients who have recent worsening. Is still symptomatic on guideline-directed medical care. Then recent heart failure hospitalization, recurrent heart failure hospitalization. They are high risk patients and they will naturally have better absolute risk reduction. This is just a guideline Dr. Balbir also made. 4 pillars. I strongly object to these 4 pillars. They are not in sequence. You should not be confused, they are in sequence. The discovery of drug is evolutionary, that we have ACRP, beta blocker, MRA, SGLT, but there is nothing of that kind of cookbook approach in using these drugs in management of heart failure. I feel they are like a school. You look at different angles in a different patient. A patient who has got low BP, RV cannot be used. A patient who has got low GFR, MRA is not used. A patient who continues to be little bit of heart failure, beta blockers are different. So individualized detection, what we say, layering of the patient and start early these drugs because SGLT2 inhibitors like atumelnant, like aldosterone inhibitor, they work very, very fast. And the concept has changed from 2008 to 2012 to today that we were sequential. We started in 2012 ACE, beta blockers. Now what we say, give small doses of everything on day one. I think that conceptualizes how you should use this drug. Every drug should come within first to 2 weeks on board so that all drugs hit the multiple neurohumoral, orthogonally opposite neurohumoral axes. That is the essence how we should distribute these drugs. Doctor, we showed you a major benefit after using all these drugs. If we combine all these drugs, there is CV death and hospitalization reduced by 42%, death by 25%, heart failure hospitalization, CV death 37%, and if you combine all of them, 50 in the nation, and we are fortunate, and community is fortunate, we are able to use these drugs. Diamond approach, you know, in literature hypertension, there are new kits on block like omecamtiv mecarbil, which is a myotrop, or very simple which is a cyclic GMP, soluble cyclic GMP donor, and that's how these 2 drugs may come on board also. Vericiguat has come to B indication. We don't have an indication. Point, ivabradine is again to a B these are additional drugs. Most of the time we use them in safety C. So new drugs are called calcitrops, which have failed because they increase mortality, and the new kids on block coming are myotrops, I told you, like omecamtiv, and microtrops, which are like medicine-wide, we are cycling GLP. This is just the last part of it. We are cardiologists, and some of our heart failure study. So this is a study which has come in Egyptian journal, a wonderful study which showed that if patient goes to heart failure clinic, 69% of them, they are receiving proper medication, beta blocker 99%, MRA 76%, but if you go to cardiologist, 30% goes down. So often we blame physicians, they are not able to do this study. First time show the less aggressive behavior of cardiologists versus heart failure specialists. So we have to match them in using these drugs and reach the maximum possible percentage eligible for these guidelines. This is a very good slide. My daughter sent this article to me from San Francisco, and this published in Wall Street Journal, that how we can heart failure. Now I think that should be future like remote sensing, that heart failure, heart rate, blood pressure, weight, SpO2, what else you need for titrating these. So I feel like the smart watches have revolutionized AFib management. And in the other hand, these kind of smart watches may change our understanding and may change the total approach in management of heart failure in domiciliary. Heart failure with reduced ejection fraction is not a cookbook approach. It's an art. You should know what is the phenotype of a patient and then profiling the drug. There is no sequence. Sequence is virtually an art of medicine, what drug you display without further destabilizing the patient and build up the whole range of drug for a patient. And this is Dr. Brownwood's corner, and I also believe that SGLT2 inhibitors are the new statins for 21st century in heart failure. So they are wonderful drugs. You should profile the patient and understand that who are the patients who need help. So ladies and gentlemen, I summarize that SGLT2 inhibitor need to use it, we need to commit ourselves, find out the patient population and try to be more liberal in the usage and change our opinion and view in management of heart failure with special reference to SGLT2. Thank you very much.
Thanks a lot, Rajiv Agrawal sir, for such extensive and great talk on this extensive subject. As we were discussing in the previous lecture also, that this is one of the dreadiest disease with 50% mortality in 5 years. And so we have added some medications and you have summarized them very well. And there is no order, but the order is that the patient should be given the benefit of the best of all. And this is not the medicine, as you have already said, this is the art. And as in our Harrison also there was some words that the medicine is just not the amalgamation of some sign and symptoms. The medicine is the overall scenario of sympathy to the patient, history and judicious act of art of dealing with the patient. So you have very well summarized this. We are blessed to have you always on this podium for CardioCon. Now I want to ask if there are any questions from the chairperson or from the audience, then we can ask of.
Thank you very much, sir. We are very much privileged to listen from you about the role of SGLT2 inhibitor in the management of heart failure patient. As you have very well elaborately explained about the role of SGLT2 inhibitor in reducing the sudden death as well as reducing renal stone formation and cardiomortality. Thank you very much, sir.
So, if there is no questions, thanks a lot, and I will ask our team to please provide memento to the chairpersons. Dr. N.K. Gupta sir. Sir is one of the senior most physician of this area, and a very academic person, always inquires about that and takes the history very well, always with a smile and with academics. Yes, Dr. Arjun Singh sir. Sir is my teacher, and I was saying to somebody, sir is the first one who has given me the job of general medicine as a SR way back, is 15-17 years back. Sir has taken my interview and that part, and I am blessed I am here. Dr. L.K.S. Sinha sir. So thanks to all of you also. So thanks a lot, and thanks again Rajiv sir for having you with us, and you are such a thorough gentleman, a great intervention cardiologist and a great person. Thanks a lot sir. So now we will move on, and this is one of the favorite topic of the of this cardiophone, and I was asking somebody from the senior physicians what should be the topic, that then it is from the audience side, and this topic is, that is very, as our Bhagavad Gita says, we all make misjudgments or mistakes, not the negligence but the misjudgments, and it is very difficult topic, but we all make. So the topic is common practical misjudgment by physicians in cardiology, and everybody should listen to it, and the speaker will be my teacher, Dr. Vivek Chaturvedi sir. Just a story I usually share when I see him. It was way back, I was just doing first year MD, I think MBBS, and just the ECG part was like that we used to write behind ECG, this is MI. अगर डॉक्टर पूछेंगे हमारे टीचर तो हम पीछे से देख के बताएंगे, आगे से तो समझ में आता मुश्किल है. In one of that session, I met, I think that was in AIMS, sir was taking a lecture on hypertension. And still I for 20 years there is hypertension galore. They say always there is confusion, what is the range, JNC changes, medication changes, but I only remember that lecture. Sir says every medicine may have any, whatever may they say, the first thing is that you should judiciously reduce the blood pressure up to a optimal range, and that is my practice for around 20 years, and that is the influence that I have of him. And now even one of the part, electrophysiology, I don't do, and I am in Navy in that. And usually I say to the patient, if you need three things, first the ethical advice, the knowledge and the wisdom, then the combination is Professor Dr. Vivek Chaturvedi sir for me, any day. And the positive part is that the feedback I have got from the patient from a long time is that they say, Doc साहब इतनी बढ़िया जगह भेजा, और उसके बाद फिर मैं कहता हूँ भैया कि सर आपके अब वापस जरूरत है नहीं, है ना. So I will request Dr. Vivek Chaturvedi sir to please join the dais and enlighten us, because this is the topic of the day, and be there, we listen carefully. And I will ask my teacher, my mentor, Dr. Professor V.K. Bahal sir. Sir is like, I will summarize this in other way, that if I have to share, if somebody says, I see a story on this TV, that Pant used to say in Indian cricket, that he want to ex-dean of All India AIMS and HOD AIMS. So, and such a humble person, that one thing I used to see, Vidya, Dr. Narayan is there, in Sanskrit they say Vidya Dadati Vinyam, and you can see sir's face, and you can आप उसको रट सकते हो इस चीज़ को. So Vidya Dadati Vinyam, and the other chairperson I will ask Dr. Anil Chaturvedi sir, please again, and virtually Dr. S.K. Gupta sir. Dr. S.K. Gupta sir needs no introduction in COVID era. Sir is one of the international personality in COVID. Sir has released his book on COVID. Sorry sir, sorry. The audience, the chairperson is like that they are the special ones. I think sir has released the book, only book on the whatever you can have. So over to Dr. Vivek Chaturvedi, sir.
Thank you, Dr. Pawan, for this very kind introduction. So I'll just.
Some resistance.
It's not frequently discussed in meetings which are more of what's happening in journals, what's happening in guidelines, what is the latest evidence. But there is something else which we must face, and that is that we all make mistakes. And that means all of us, whether it's me or whether other esteemed chairmen sitting on the dais or any of us. So, slides are not moving.
It will be mild, it will be midway. It will be midway between UK and South Africa. And disease will
Yeah, so as I said, we all make mistakes. And I think that is the part of ongoing learning for each and every physician who is there. Second point, very important, is that even cardiologists are primarily physicians first. And all the mistakes which I would enumerate here, rather I would not say mistakes, but sometimes omissions or lack of judgment or lack of skill or knowledge, they are all actually shared by cardiologists as well as general physicians and nephrologists and endocrinologists and neurologists, the entire spectrum of the physicians. So a very important thing is that we learn from our mistakes so that at least some of them are prevented the next time they are about to happen. And that is how we evolve and we increase our clinical acumen and judgment. There are several scenarios in cardiology with a potential for misjudgment. In cardiology, this misjudgment actually can have very serious consequences, and that is why I am discussing few of them here. So coming to the one which is the most common one which we all encounter, and that is acute coronary syndromes. Acute coronary syndromes, despite at least 100 different journals publishing thousands of articles every year for the past 50 years, is still an enigma to even seasoned cardiologists. In acute coronary syndrome, in terms of misjudgment, there are two possible scenarios. One is that one misses an acute myocardial infarction, and the other is that one overdiagnoses acute myocardial infarction. The latter, which is overdiagnosing acute MI, is not of much concern. It is like a surgeon opening too many abdomens because of the suspicion of appendicitis. So even if you open a little bit extra, it's okay. You don't want to miss a burst appendix. Similarly, I think there is nothing like overdiagnosing acute MI, especially in the Indian context when we are seeing acute MIs left, right and center in rickshawalas, in young people, in gym going people. I think overdiagnosing acute MI probably is not a bad thing at all. Again, I think most of the physicians in India do not miss a STEMI because that is something which we are all very experienced in seeing and managing. However, do remember that up till 30% of myocardial infarctions can actually have very subtle or non-diagnostic ECG changes in the beginning. So this concept of dynamicity of the ECG is very important to understand, because as a myocardial infarction is evolving, there is a thrombotic occlusion of a vessel. In the beginning, because of the body's own fibrinolytic process, there might be a stuttering kind of a picture, which means that a thrombus forms, person gets chest pain and gets an ECG changes, and after that maybe some part of the thrombus is lysed, the flow is restored, and the person may feel better, and the ECG may also change. So this dynamic changes in ECG is the reason why in most of the people who are who have to undergo evaluation for acute coronary syndrome, we say that an ECG should be repeated at a certain interval, maybe 15 minutes or half an hour, to look at dynamic changes. Again, the other important part is that even if there is not a stuttering STEMI in process, there can be very high grade plaques, and because of which certain changes, especially in the left anterior descending artery, can be present. And these, like De Winter sign or Eslanger's pattern, there are many of these, and we will not go into the detail, but they all are a harbinger of a occlusive event and even SCD, and that is why it is important to not miss these people, even if they are not traditionally in that STEMI kind of a picture. So in whom are ACS missed? If the chest pain is very typical, sometimes we may ignore them because the patient is not typical. So that can be a young male or a premenopausal woman or a very, very elderly person, somebody who has had some aches and pains for a very long time. The other part where ACS is missed is when people have atypical symptoms. So typically a person with diabetes who has had, he's got SAR eructations and he's belching for the last couple of days and feeling very uneasy, or somebody like an elderly who just has a syncope or just feels profound fatigue, or somebody who has comorbidities like advanced COPD, he's breathless, he always has chest congestion, but now he has got some more chest congestion and he can't actually express, and we also are not able to understand it. So here I would like to introduce to you the concept of pre-test probability. The concept of pre-test probability is central to decision making in almost all the fields of cardiology. So basically what it means is that whatever test or whatever algorithm we apply for reaching to a diagnosis, the outcome of that algorithm is dependent on the probability of the person having that disease in the first place. Because each test, whether it is history taking, whether it's ECG, whether it is a cardiac enzyme, has a sensitivity and a specificity. It basically means that the test can never be 100% accurate, and because of that you need to know in what context are you applying this test. So when we talk about ACS, the pre-test probability is dependent on certain criteria. So one is obviously symptoms. So somebody who has a chest pain which is compatible with an acute ischemic process. So somebody who has a pain which lasts few seconds or something which lasts continuously for 3 hours obviously can't be an ischemic chest pain. But typically if somebody has a chest pain or discomfort which is there for maybe 5 minutes to 30 minutes, then you would think that yes, this could be ischemic chest pain. And similarly, people think that it has to be in the chest, but it could be in the right arm also, it could be in the abdomen, it could be in the jaw, anywhere. So the symptomatology is important, and so is the cardiovascular risk. So cardiovascular risk assessment is also a part of this pretest probability, because if you have diabetes, hypertension, and you are a smoker, and you have a family history of premature CAD, then your risk of having acute event is much more higher than a young premenopausal woman who has no risk factors. So this is also important to determine. And then the ECG. So if ECG is obviously diagnostic, certainly the probability increases a lot. But if the ECG is non-diagnostic, it decreases but doesn't become zero. So somebody who's a smoker, has diabetes, hypertension, has typical chest pain, But a normal ECG, his pretest probability still remains very high, and hence one cannot discount an ACS in this person just because the ECG is not diagnostic. And then this concept, which is actually legally mandatory now, that all the heart attacks have to be documented by an enzyme, which is suggesting release of myocardial necrosis, enzymes released by myocardial necrosis. But what we sometimes, because now troponins are so good, they are so sensitive and accurate, we do forget that it takes time for them to get elevated. So suppose somebody comes to you with a 1 hour chest pain and you do a troponin, it is negative, doesn't mean anything. It could still be positive after 4 to 6 hours. On the other hand, if somebody who has a pneumonia and fever and sepsis, he can also have a little bit of troponin rise. But if he doesn't have the other picture of pretest probability, then the chances of ACS, despite troponin being high, are actually low. So the concept of pretest probability is very important to understand. So the other part is obviously what we miss, and that causes a misjudgment, is unusual but suspicious symptoms. Again, as I mentioned, they should be in a clinical context. For example, a person who was in my hospital on dialysis, non-hypertensive, non-diabetic, he had kidney disease because of some other reason, kept on having severe symptoms of upper GI symptoms for 2 to 3 days, consulted the nephrologist, was given pantoprazole, didn't go away, so pantoprazole was increased to BD, then Pentocid DSR was added, then maybe Digene was added. But if you would go into the history, he would tell you that he never had dyspepsia to begin with. So something in an older person who is at risk, because obviously CKD is a risk factor for CAD, somebody who's older, who has a risk factor, who has a new onset dyspepsia, that is a reason enough to suspect ACS in this person, and a simple ECG and probably an enzyme test would help us in this picture. Similarly, there are many elderly people or postmenopausal women who are having dyspnea, fatigue, or even palpitations, and an acute coronary syndrome is missed. Then there are low-risk groups like young males who can have persistent symptoms or symptoms with some residual effects which are not very typical, but because they are low risk, it is missed again. So for example, a gym-going person came to me because he had chest pain for 5 minutes, but then it went away 3 days ago. And after that, he was just feeling a little bit of lethargy and fatigue, which he ascribed to his, gym going. And he kept on going to the gym even after that. But because he is young, despite having a good enough infarct on the echo, he was able to carry out his normal activities of daily life. And he definitely had suffered an MI 2 days back. And this was missed, obviously, because he had very atypical symptoms. So if you look at this ECG here, it has, on the face of it, this ECG looks fairly innocuous. If you really try to look deep into it, you may say that there is some ST elevation in lead 2 maybe, and there is some ST elevation in lead V4, V3 and V5, but this could be easily passed off as normal. But is the person in whom this ECG done is normal? No. He is a 60-year-old smoker with acute crushing chest pain. The pretest probability tells us that he is very high risk for having an acute coronary event. In fact, this person, when underwent an angiography, had a mid-already 80% thrombotic occlusion. And it becomes clear if you look at this ECG afterwards. So you can see now that the changes were in fact indeed dynamic, because all that ST elevation which was there in V4, V5 and lead 2, all that has subsided. So again, the message here being that, acute coronary syndrome is such a serious thing that one cannot afford to miss it, and you have to, really take out all your guns to identify it. If that means repeating ECGs in a person who is highly suspicious, please go ahead and do it. The second misjudgment comes in diagnosing acute heart failure. Now, acute heart failure, as we all know, can actually be with reduced ejection fraction, but a person may not have the LV dysfunction for diagnosis of heart failure. This becomes very difficult even for very seasoned physicians and cardiologists if there are comorbidities like COPD, renal failure, and severe obesity. And that is why natriuretic peptides were actually being commercialized. For this purpose only, they were used right from the beginning, was to differentiate them from lung disorders, with whom acute heart failure has several similar symptoms, including shortness of breath, and somebody with COPD can actually have something like orthopnea, because the moment they lie down, they can't use their diaphragmatic muscles well. So almost all the picture of a heart failure can be mimicked by a person with lung disease or COPD. Now, many of these people are actually, they would come to a very busy OPD or to an emergency in the daytime, and somebody would give a cocktail of bronchodilators and furosemide, and then they're discharged because they feel better. Something has to work, so they feel better and they're gone, and this is perfectly fine. I think anybody coming up, seeing a person who's very breathless would probably not want to waste time and give all the things, and bronchodilators actually do work in heart failure also. So you give in a cocktail and you discharge them. The problem is not of the medicine, but the problem is that nobody has risk stratified these people. If you don't risk stratify them, then some of them actually may not ever come back to any hospital ever again because they are gone, or they may be brought back to you or to another hospital in a gasping state. And that's because, well, we gave them acute treatment, the condition progressively worsened. And this happens, like I said, because some of them will actually improve a lot even with simple bronchodilators because of change in the VQ ratio. So again, the other point which I have practically felt, and I think Dr. Bahel sir, I would like to ask his opinion about this also, and it has always confounded me, is that many of these patients, they are brought to you in a, they are breathless, but they are brought to you in the casualty, and you see them, you make them lie down, you give them oxygen, and after some time they are actually gasping. And the attendants are saying कि हम तो ठीक ठाक लेके आए थे, ये अभी हालत कैसे हो गई है? And to my mind, the reason for that are twofold. One is that they have a sympathetic drive which is going on, and because of that they are able to maintain a homeostasis. The moment they are brought to a hospital, they just let go. And it is kind of a mind-body thing also, because the moment they let go, their body mechanisms also start letting go. So that is why it is very important that in people who are breathless, we don't go by vitals alone. So, if somebody has good blood pressure, maybe a little bit of tachycardia, sinus, doesn't mean that he's stable. Even if the blood pressure is 140 systolic, doesn't mean he's stable. If he's breathless, there is a good chance that he might deteriorate after 15 minutes or maybe after 15 hours when you send him back home. So in these people, it's always a good idea to do an ECG, to do a BNP or anti-proBNP level if they can afford it, because it has a risk prognostic value, and a blood gas just to look at acidosis, hypoxia, etc., and a kidney function test, because again, that is also has a prognosis in these patients. Another important point in these patients is that sometimes after doing everything, triage and emergency, they start becoming, slightly altered sensorium or obtunded sensorium. And we start thinking of that, okay, I gave morphine, or maybe I gave this or that, or it is hypoxia. But more often than not in these people, it is also hyponatremia, especially in the elderly people. And so that should always be checked in these people. And as I mentioned, it is hundreds of people I have seen now with very bad hearts, with very large rises in troponin and proBNPs. But if they are young, as I said before, they are able to tolerate it well. But the ability to tolerate well today doesn't mean that it will be there tomorrow also. So again, as I said, these people will be very compensated when they appear to you, but this compensation may actually be a transient thing only before it hits the ceiling. So this is a case so this was a 70-year-old woman with diabetes, hypertension, normal heart function because of a routine echo done 2 months ago. Now she presented with some cough, some shortness of breath, uneasiness and inability to sleep, nothing major, all minor symptoms, which could be completely ascribed to her being, a little bit old. And because of this COVID thing, and this is another very important thing, is that we do so many remote consultations where, our misjudgment are likely to actually get amplified. So she was advised some antibiotics and cough syrup. Because she did not improve in 2 days, the conscientious family brought her to the hospital actually, where again she had borderline blood pressure, sinus tachycardia, some ECG changes, some craps here and there, nothing major actually. The troponin was also mildly high, but BNP was 900, not anti, but BNP, brain network pet type, was 900. So that is, something more than 100 is definitely abnormal. So we went ahead and did a screening echo. LV was just 30%. Severe LV dysfunction. So obviously with diabetes, some troponin rise, some LV dysfunction, angio was done, which is normal. So now on direct questioning, she says that she has had extreme stress in the past 1 week because of the demise of a very, very close friend. So classical setting for a Takotsubo cardiomyopathy. She was admitted for 3 days. 1 month later, she's absolutely asymptomatic. Heart is already recovering. The issue is that if she had not come to the hospital at the right time, she may actually have never made it, because many of these people actually have arrhythmic deaths in house itself. And that brings us to the third misjudgment, which is of cardiac arrhythmias. Cardiac arrhythmias are a classical thing for misjudgment, because many of these are actually fleeting in character. They are paroxysmal, because of which, if they are not in front of your eyes in the ECG or in front of you in terms of a racing pulse, then it is out of your mind also. So a lot of these are actually diagnosed as anxiety or malingering. Even when they are diagnosed, appropriate treatment may not be given. So you may actually, somebody who has a past MI, who has a ventricular tachycardia with 130 heart rate, he comes to you walking, he says, I'm having some palpitations. So you say, okay, I'll give Cordron and send him back home, just because he is not having any syncope or pre-syncope. But that is something, again, as I said, these people are very precarious. The moment, there is a good enough chance that at least 10-15% will have an acceleration once they go home, and they may actually never be able to make it. Similarly, somebody who comes to you with a 2:1 AV block, he says, I'm fine. Because of corona, I've just checked my pulse. The heart rate was coming as 44. So I've come to you for checkup. I have no symptoms. He is a quarter 2:1 AV block, but he is a 70-year-old male. Well, this 2:1 can actually become advanced at night when he is sleeping because of the vagal tone, and he may actually have an SCD at home because of that. So once this is done, appropriate treatment also has to be risk stratified. And as I said, that many of them have a normalish looking ECG, and so that is why, and they are fine at that particular point. So the proper assessment is missing. Anybody who says that I passed out 1 hour back should be taken seriously, even if it is completely normal on every parameter. If he has a history of loss of consciousness, it has to be taken seriously. And the best way to do that is to look at the periodicity of the syncope, for how many years it is persisting. Naturally, something which is persisting for a very long time is likely to be benign, while something which has happened just now can obviously, it is more concerning. And what is the underlying heart disease status? So a syncope in a 15-year-old or 16-year-old girl after seeing some, trauma on road is different from a syncope in a person even with a normal ECG who has had a CABG and whose LV function is 35%. So that is why the ascertaining heart disease status should be always a part of somebody who's undergoing an arrhythmic workup. And then an ECG should always be done, because there are clues on sinus rhythm of people who actually can go on to have an SCD. So you can, this person, this girl with that ECG of a WPW she went around, in many places. She has had history of syncope and getting up and becoming better again. But, WPW, most of the people will say, fine, it's not, you will get PSVT maybe, that should not cause syncope. Well, look at the ECG below. So she has had AF with very fast ventricular response, something what we call as FBI, fast, broad and irregular heart rate. And this is perfectly capable of causing syncope and even death. And that is a very tragic thing to happen in a young woman. Then there are other substrates of SCD. For example, look at that PVC on the top. Now, this PVC, the implications are different if it was happening a little bit later than QRS. But look at how early it comes, right when the T wave is about to start. This is a classical, substrate for this PVC to degenerate into polymorphic VT and VF, and the person can die. The ECG below, somebody comes to you with syncope of this, maybe 60% people worldwide will actually send this person home. But this is long QT syndrome, and the syncope was because of a torsades. And that syncope, it recovered, the torsades finished, the person becomes fine again. So that is why an ECG, a simple ECG which spent 1 minute on looking at the possible arrhythmic clues, should be enough to screen out people who are low risk and can be discharged home. So this is a 75-year-old doctor. She's a gynecologist, and she consulted me because, again virtually, because she has had 2 AF ablations. And now she is having some family stress, so she gets palpitations. So the son, who's also a doctor, consulted me and says that she is having sinus tachycardia. Off and on, morning she has a 120 heart rate, by evening it becomes okay. This lady is already on 420 mg of diltiazem per day, along with amiodarone. Can this be sinus tachycardia? Very, very unlikely, unless she is very sick, she has LV dysfunction, there is a lot of sympathetic response. But if none of them is there, then this cannot be sinus tachycardia if somebody is taking 420 mg of diltiazem and Cordron. So this is actually atrial flutter, which is very common after AF ablation. But this can easily be missed if we don't do ECGs at different times. If you look at this ECG, it becomes clear that the heart rate is irregular. There are many more P waves than QRS. So this is atrial flutter, which can look like a sinus tachycardia several times. So that brings me to the last judgment in one of the most commonly treated disorders by all of us, and that is hypertension. So hypertension, there are several mistakes which all of us do, physicians, nephrologists, endocrinologists, cardiologists, everybody who looks after hypertension. The biggest thing is we take hypertension less seriously in young patients. By that, I don't mean that we don't give them treatment. Obviously, all physicians give antihypertensive treatment whether the person has high blood pressure at age of 18 or 80. However, we never actually do adequate target or organ damage workup in these people. Do remember that a damaged target organ, which could be kidneys, heart, it could be retina, or it could be brain, can be a big blow to a young person. And while this may not happen in the next 2-3 years, it is bound to happen, and there are enough technologies available today to screen for this target organ damage and prevent it from progressing further. Also, in the times of COVID, there are a lot of virtual consultations, and people are very anxious. So actually, I've had 3-4 cases where 30-ish-year-old people were prescribed antihypertensives on a virtual consultation without realizing the fact that there could be so much of stress in the family because of COVID-positive family members that you were likely to have high blood pressure because of the stress itself. It's a sympathetic response. So there was a young journalist who, he fell down, he had a fracture, all because he had a lot of stress. He was given one blood pressure medicine. After maybe 6 hours, he rang up the physician again. He says, "Doc, my BP is still 160. So he was given one more. And then third the next day. And then he kept on taking all the 3. And finally, he landed up with a fall and an injury. So that is why in all the people who are little bit, atypical for having, severe hypertension, I always ask them to take at least 3 blood pressure readings, spaced at least 1 to 2 minutes apart, because by the time you sit down quietly, don't move, heart rate comes down, the sympathetic outflow comes down, and the person becomes little bit better and the hypertension can be managed. Always remember that in 90 or maybe 95% cases, if you have given a good antihypertensive, or maybe 2 at the most of them will not have an acute hypertensive, pulmonary edema or stroke or, kidney shutdown. Even if the BP is 180, doesn't matter. If he's on a good amount of antihypertensive already, you don't have any, immediate hurry to step up your antihypertensives. And that brings me to something which is very critical for physicians in Delhi, and that is the seasonal changes in blood pressure. In Delhi, we see almost 10 millimeter changes in blood pressure just because of the winter being arriving. So when the winter arrives, it's not a problem. Somebody has on a lower dose can always be stepped up. The problem comes when summer comes, because now somebody has forgotten to step down the antihypertensive treatment, and people will start having postural giddiness, and some of them might actually fall also. Similarly, as I said before, the overzealous reduction of blood pressure is always detrimental. In my practical experience, it takes almost a week before the full antihypertensive ability of any drug becomes fully manifest. So don't be in a hurry to add medicine upon medicine just because the patient is demanding. One should always, because as I said before, even if there's a good amount of one antihypertensive, it's very unlikely that somebody will go into an acute renal shutdown or acute pulmonary edema. So always build it up very gradually, otherwise it might have disastrous consequences. And finally, I think something which is not related to cardiology but overall, and that is we all prescribe just too many medicines. For each and every symptom, we tend to give one medicine. And that is why in COVID era, we had those, parchas circulating in which there were 2 pages of prescriptions. So that is not a good idea, not just because too many drugs means too many interactions also, basically also because the essential ones just get lost. So, if you're giving 3 vitamins and somewhere along you've written aspirin and clopidogrel also, and then another 2-3 cough syrups, people are human beings, they will actually have, will not have good compliance in the long run for any chronic medications. If you write too many, then there is a good enough chance that he may forego to take the essential one also, because there are just so many of these medicines. So with that, thank you so much for your patience listening.
So thanks a lot, sir. And I can say one word, that the ECGs and elaboration and such a difficult topic that if anything else would have been, I would have said once more, sir, if no constraint of time. So it was so enlightening, and all the 4 things sir has discussed. When I was discussing, sir has said this is a good topic. I was realizing nobody would take this topic. The common misjudgment by all of us, because we are human beings and we make all the misjudgments. But sir has nicely taken this, covered everything in cardiology. If any comments from the chairpersons first, and then I will pursue.
Thanks, Vivek. It was enlightening. I think what is human. Most of the time, I think we don't make mistakes because we don't know. Sometimes, occasionally, yes, there may be some syndrome which we may not know, because as they say, the eyes only see what the brain knows. That's occasional. But my take is that most of the time, patient will tell you his diagnosis, but we don't have time to listen to him. you don't emphasize to him that you have to continue that EAPT after 7 days also, many of the time patient thinks that this is for 7 days, then I'll go to the patient. And so your all hard work is gone because he has missed his EAPT. So these are small examples where there is no knowledge is required, it's only the time which is required, and we are short of time always. Number two, I think I'm an old timer, maybe we learned from Professor Ramesh Roy there, Dr. M.P. Gupta is there. Our time stethoscope was used to be there. Now I believe in America, 7 of the medical schools have stopped stethoscope and they are going to the ultrasound. And Chakat was from our place, you know, Narola. I think he started that thing, that stethoscope is no more required for MBBS. You only go for ultrasound, portable ultrasound, and you can get everything. That's a blunder, I think. Whatever he may say. Because patient may come to you with angina, just put the stethoscope, you find the injection murmur. You know, most of the time, it's not most of the time, but I have seen patients, occasionally everyone has seen, the patient has undergone an angio and your stenosis has been missed because echo was not done. Or the stethoscope was not put. I'm sure if the stethoscope was put, they would have diagnosed, if not aortic stenosis, severity may be less, but they would have gone for an echo and done the things. On the other way, we depend too much on investigations. So most common reference I have seen after coming here in the private sector is the troponin is raised. For each and every reference, if patient is renal failure, patient has severe infection, patient severe, all ICU references to the cardiologist, so troponin is raised, and whether it requires an angiography or urgent intervention. So we should, as you rightly said, we should take the investigations in the context it is said. So that what you term as pretest probability. There is so much of grey zone that is not erring only. It's because we don't know what to do of those patients which are so called. Because if you do an angio or investigation patient and it comes to normal, patient is overdoing the test. And then if you don't do, occasional patient you will be missing. So we have to have a fine balance that should every patient of headache should have a CT angio to rule out brain tumor, or every patient of chest pain should have an angio to rule out. So those are the things I think it comes with the experience. The medicine is the art, it's not really a science. And you have very elaborately pointed out all the four, like coronary, heart failure, hypertension. So everyone will learn, but I think we are basically at fault that we are not giving the time the patient deserves to have. That's my take.
Thank you, Dr. Vahan. Like a true teacher, he has explained everything, and I think, like his name, Vivek, intellect and wisdom, his talk is very full of illustrations with common problems which we generally face. And as Professor Bahal has said, and I am also saying, which I have talked in the first lecture also, please remember, communication is the most powerful therapeutic force with the physician. Whether it is a physician, family physician, cardiologist. 3 years back there was an article in Times of India, news item. A physician gives only 3 minutes to the patient. Lord Platts once said, more and more you talk to the patient, more and more he will tell you what is wrong with him. So, listening to the patient is an art, communication art. And unfortunately, today we are so busy. The technology has, as I said in my article, technology has already transformed the art of conversation with the patient. And that is the most important part. Secondly, as far as the blood pressure is concerned, most of the patient comes in rush, we start taking the blood pressure and start prescribing medicine. Please wait for half an hour. Day before yesterday, I saw 2-3 patients. They're all alcoholic, they're all young men. They were all taking either tobacco, vodka, or smoking, and the BP were 160 by 100, 150 by 100. And after half an hour, everybody's blood pressure was 130 or 80. So please ask the patient, whether you have taken smoking, tea, coffee, you take gutka, tobacco, wait for half an hour or so and recheck the blood pressure rather than rushing and writing the medicine again and again, as Dr. Vivek has already said. I think his talk was very lucid, very practical, and we must laud and applaud for it.
I would just like to offer you proof of what I have said. And as Dr. Bahal sir is saying, I think history rules as far as cardiology is concerned. No amount of nuclear scans or CAG can actually surpass history. Look at ischemic heart disease. How do you decide revascularization? Depending on the symptoms. If somebody has class 2 angina today, you may say that, okay, take anti-anginal. Somebody has class 3, 4, you say take straight to the lab or take straight to the OR for a bypass. Look at heart failure. Somebody with an LVEF of 35%, if he is very breathless or if he is not breathless, depending on that, your treatment totally changes. So, history, I think, is the most critical component, and that is why the NYHA class is still, and thanks to Dr. Bahal sir and other teachers and names, this is the lesson that we learned in cardiology, was to have a complete cardiac diagnosis. And that diagnosis was never complete without mentioning the functional class of the patient. The functional class of the patient is the most important thing to determine treatment and prognosis in a cardiac patient.
Thank you, Vivek, and thank you, Dr. Pamesh Sharma. We have been attending so many cardiac conferences, but this topic, the commonly missed diagnosis by the physicians, I'm hearing for the first time. This is really, really commendable. I missed an inferior MI when I was a postgraduate student at 25 years of age. I still miss inferior MI after 30 years of practice. It's not so uncommon. And we continue to keep learning all through. Maybe sometimes we are in a hurry, sometimes the symptoms are different, and sometimes the ECG is settled. But we are always going to look forward to the cardiologists to guide us more and more in times to come. Thank you very much.
Thanks a lot to everybody.
We conclude the session.
One thing I want to ask for the benefits, basically there is between the investigation between COPD and CHF. Could we depend on pro-BNP or something? Because there are audience which are even general physicians and